You can't guarantee that one person doing something will have an impact on culture, but you can certainly guarantee that doing nothing won't do anything to challenge a toxic culture, and so it will just perpetuate.
You are listening to the Medical Protection Podcast, Good Medical Practice series. Hello and welcome back. I'm Dr. Claire Stapleton, and for today's podcast, I'll be joined by our previous co-host, Jalen Simsek, and I'm pleased to say our previous guests, Yael and Tista from the GMC. In our previous episode, we talked about the changes that have now happened to good medical practice, how these changes will impact doctors in the UK, and the stakeholders that GMC have liaised with. In today's episode, we would like to discuss a key theme that has been expanded on in the updated version of Good Medical Practice, and that is creating a compassionate workplace. Yael, there's much more focus in these updated standards on improving cultures. What inspired the GMC to include this?
Sure. Well, since the standards were last reviewed, there's been mounting evidence of the damage that negative workplace cultures can have on patients' care and patient safety. The medical profession, and particularly hospital environments, are traditionally very hierarchical. Even today, I think you'd be hard-pressed to find a newly qualified doctor who'd be confident enough to openly question the actions or decisions of a more senior colleague. And environments where people don't feel that they can challenge something because they think they might be wrong, where they can't talk openly about mistakes or even ask questions because they're worried they'll look stupid. Those aren't environments where people can be effective learners or do their best work, and patient care inevitably suffers. So in good medical practice, we start from the principle that everyone has the right to work and to train in an environment that's fair, free from discrimination, and where they're respected and valued as an individual. The good news is that as well as evidence linking negative culture to lower standards of care, there's a range of evidence out there which shows that respectful, fair, and supportive working cultures enable good, safe patient care. Our Workplace Experiences Report 2023, which was based on in-depth interviews and annual survey results, we discussed how positive cultures can protect doctors' well-being and benefit patients. There's evidence in there that being part of a supportive team and having a strong sense of belonging leads to higher staff satisfaction and better patient safety. So there are several of the professional standards in good medical practice that are geared towards creating these types of environments, about role modeling positive behaviors, about listening to colleagues, communicating clearly and considerately, and about working collaboratively with colleagues, recognizing and respecting people's skills and contributions, and also treating colleagues with kindness, courtesy, and respect.
Thank you so much for that. On the topic of kindness, the updated Good Medical Practice also introduces a new duty, and I'll read this out for our listeners. You must treat colleagues with kindness, courtesy, and respect. So, some of our listeners might say kindness is a highly subjective term and be concerned about how this would be measured. If, for example, there was a complaint to the GMC, how would you reassure those doctors that the GMC's analysis of a doctor's behavior would be fair?
Yes, so how could I reassure doctors that the GMC would be fair if a complaint was made about them in relation to kindness? I talked about the fitness to practice processes in the last episode when I said that good medical practice isn't a fitness to practice document. Rather, it describes good practice. The name is a bit of a giveaway. And not every departure from the standards will be considered serious. We always take account of the individual circumstances of any concern and consider context, the doctor's experience, system factors, interpersonal factors in the working environment, and so on. Have a look at the introduction to Good Medical Practice for more details. On the point of why we included the word kindness specifically, partly we wanted to mirror the duty towards patients, which we might, well, talk about it in another episode. But also, being kind to colleagues is about respecting and valuing people as individuals. It doesn't mean you can't challenge a colleague's decision or even raise a concern about their practice. It just means doing those things while respecting and valuing them as a person. We all know what unkindness looks like and feels like to be on the receiving end. It interferes with our ability to do our work. There was strong support throughout the review for making sure the standards encourage civil and respectful behaviours between colleagues, because these behaviours enable good teamwork as well as supporting individual well-being. That's why we included it in the final version.
And Tista, would you like to add anything to that?
Yeah, absolutely. Just building on what Yale said there, I really want to underscore that this is about inculcating positive cultures. I'm sure you and listeners will be familiar with some absolutely egregious stories of how, for example, some trainees have been treated, how minoritized doctors have been treated on occasion. And as Yale was saying, thinking back to the consultation events that we ran, once colleagues understood that GMP is that set of ethical standards and not fitness to practice thresholds, as Yale has said, there was a lot of support for kindness, particularly from groups of doctors who traditionally have less power.
Thank you, Tista. I've got another question for both of you. Some of our listeners might say that, in large organizations particularly, the culture of that organization will be influenced to certainly some degree by the behaviors of non-regulated professionals, particularly those at a managerial level. I wouldn't want for 1 minute to debate the thorny subject of whether medical managers should be regulated or not. But are the GMC optimistic that the medical profession adhering to this guidance can change an organisational culture for the better?
Completely agree that it isn't just the responsibility of doctors to help create these types of cultures. Individual doctors have a role, but so do other healthcare professionals, managers, and other organisations. I'll ask Tista to talk more about that in a second. But just to say, we recognise that the power of any individual over an organisation's culture is going to be limited, especially if they're a junior member of staff. But we can all role model supportive, inclusive behaviour ourselves, and we can all do something to prevent negative behaviours continuing. For example, if someone witnesses bullying or harassment and they don't feel safe to challenge it or call it out in the moment, that's fine. But maybe speak to the person who is being shouted at or harassed afterwards. Say that you saw what happened and ask them if they're okay. They might be embarrassed and not want to talk about it, but at least they'll know that it wasn't just in their head and that they were being too sensitive or something. The point is, don't do nothing. You can't guarantee that one person doing something will have an impact on culture, but you can certainly guarantee that doing nothing won't do anything to challenge a toxic culture, and so it will just perpetuate.
And I know from our previous episodes, our listeners will have heard that the GMC have engaged with lots of stakeholders, including trusts. And when you've gone into trust to discuss these sorts of themes, how has this been received?
It's actually been received really well, and that is despite the pressures out there. We have had employers say to us that some of those duties that are much more explicit about bias and discrimination and the wider culture have really given them that added weight, or I guess that lever that I was talking about last episode to encourage earlier learning interventions. So, just by way of example, I was at an organisation where they'd had an incident relating to poor behaviours. And because it didn't cross a traditional HRE type threshold line, if you will, for HR processes, they weren't quite sure how to address it. And our workshop and seeing our new standards helped them both manage that particular incident and think of a way forward as well for those regular learning interventions and development on bias, microaggressions, on overt discrimination and culture more broadly. So yes, it's been landing really well.
Thank you, Tista. That's really interesting to hear about how different organizations are supporting doctors. How will the GMC support healthcare professionals when trying to demonstrate these values and also navigating through challenging work environments.
Thanks, Jalen. I think that's a really important point. When I speak at conferences, I often say that the more that we can all do to help colleagues deliver standards in an increasingly challenging environment, the better. Feedback that we've often had is that, of course, colleagues agree with, well, let's take paragraph 58 that Yale was talking about just earlier. And that talks about the actions that you could take as a bystander when witnessing those discriminatory behaviours. So Yale talked about the checking in or challenging. Now, of course, colleagues agree with that as a concept, but as we've seen, as we've said, it's not always easy to do. So in addition to our online resources to support colleagues on the ground, so things like the Ethical Hub, and I'll just take a moment to plug that, because do have a look at our other learning resources online. In addition to all of that, I mentioned last time that my team run these workshops to help doctors apply those standards. And those workshops really delve into the hows. So they equip colleagues with techniques, with resources, with signposting. So they have things like case-based discussion. They get to practice the difficult conversations. And the feedback that we have from those workshops really demonstrates that not only is there greater knowledge of the standards, but also that they feel empowered to change practice. And that's the goal, that help on the ground.
Thank you, Tista. That's very reassuring, that degree of support, I'm sure, for many of our listeners. Just turning to a slightly different subject. Most people who review the guidance will note that there is more emphasis on obligations for those in a leadership role than previously, and specifically now with a separate section on leadership responsibilities and their responsibilities to create a compassionate and respectful workplace, as we've been discussing. What's brought this to the fore in the new guidance?
Yes, that's a really good point. We were very keen to have a separate section on leadership responsibilities, but it's important to just note that that bit applies to all doctors because, of course, good leadership behaviours, whether you're in a formal leadership role or not, contribute to the positive cultures we're talking about. And that's the why, if you will, for inclusion of that section. But you are right that we do highlight those informal leadership roles as well, especially in terms of creating the right cultures, given the power differentials we're talking about, and ensuring fair access to training, to development, to employment opportunities. We first made that kind of distinction between leadership responsibilities for all doctors and those informal leadership roles in Leadership and Management for All Doctors. So that was over 10 years ago now. And as I say, it's because we recognise those different levels of power and influence. And that brings me to paragraph 59, actually, which is one of the paragraphs where we cover those informal leadership roles. And that particular paragraph is a perfect link to the bystander actions we were talking about just now. So, as we've said in paragraph 58, we have those bystander duties, and the language is should, not as that abrogation of responsibility, as we've said, but as a recognition of the potential power differentials and inherent difficulties. For paragraph 59, on the other hand, which is directed, as I say, at those informal leadership roles, we say that if you have those roles, you must act, and you must act in terms of addressing the issues, providing support if needed, escalating if needed, etc.
And that's interesting because, I wondered whether the more prescribed obligations, particularly the last that you've talked about, would this infer a risk that trusts would have a lower threshold for instituting a disciplinary process, when these sort of behaviours are witnessed? in their anxiety to fulfil their obligations?
Yeah, it's a good question, Claire. And I know you're talking about trust HR disciplinary processes, so I'll come to that in a moment. But again, I think because it's important in terms of reassuring listeners, I want to just emphasize again that in terms of fitness to practice thresholds, as we've said, those haven't changed. But speaking to those disciplinary processes at trust level, we're actually hearing that trusts are finding this is more of a positive lever for those early interventions, like the example that I gave earlier. Disciplinary processes can often come too late down the line because by that juncture, colleagues and possibly patients have been harmed. Now, of course, trust will always need disciplinary processes, but these standards are empowering them further to create that cultural change. So I'm working with one area now, which are using the standards on sexual harassment to build learning interventions. So teams are talking about what good looks like and what actions they can take, what protective factors need to be in place. So I guess to round off, yes, there is more expectation for formal leaders, which is absolutely right for the reasons that we've discussed. But rather than thresholds, this is very much about creating change, about creating compassionate cultures. And the trust that we've been speaking with are certainly seeing that.
That's very reassuring, Tista. Thank you very much, and very interesting to hear. And with that, we reach the end of today's podcast. Thank you, Tista Chakravarti Gannon and Yael Bradbury from the GMC for joining us today. I've been your host, Claire Stapleton.
And I've been your host, Jalen Simsek.
Thank you very much for listening. We hope you found this as interesting as we have. For more information about what you've heard and our speakers, please go to the link in the podcast description. And we look forward to you joining us for our next episode in the Good Medical Practice series.